morning. It's a pleasure to be here. This is a wonderful venue, and I'm really looking forward to today's discussions and planning on learning a lot. First, let me say that Joan really was disappointed that she couldn't be here today, but she is recovering. As Leonard said, she should be fine. I'm sure that she'll watch this. She was very interested in hearing what everyone had to say, and I'm sure she'll watch the ultimate video that comes from this meeting. But today, this is sort of the super interactive part, which is why you have those little calculator-like looking things in front of you. And the committee, the planning committee, the organizing committee of this meeting decided that it would be a good thing to sort of take the temperature of the room by asking you, the audience, what you feel about a variety of issues. And for some of those issues, we're actually going to provide some feedback from a recent survey just to see how this audience compares to a patient sample, or not a patient sample, a random sample of the California population. Let me just make a quick statement about the importance of asking people about how they feel, about what they want, because I think in the medical profession this is often overlooked. And it turns out that the center that I direct has as its mission the goal of trying to improve the validity of information that people collect, that we collect from people, including quality of life issues, subjective well-being issues, and also devising new ways of getting into people's everyday lives. So we do a lot of work that is ecologically valid. We go and we study people where they exist in their everyday lives. And I actually think that many of the techniques we use could have an impact on some of the end-of-life issues. So if anyone wants to follow up, I'm sure you can find my email at USC. I'd be happy to chat with you about that. So we have a very diverse audience here, people from lots of different walks of lives, and that's why it's particularly important that we do this poll, that we find out how you feel about some of the issues. Hopefully this generates a bit of discussion right now, but it will also inform the later speakers and discussion group leaders about where you are at. So I think to do that, what we'll do is, I can see here, go to the first slide, and what I'd ask you to do is I'll read the question, you can read the options, and we have 8 questions, by the way. The first few we have some feedback about from this California poll. Let me say a word about that first. The poll that I'll be talking about and providing feedback is from about 1,700 people that were surveyed in 2011 under the California Attitudes Towards End-of-Life Issues survey. And about 400 of those 1,700 had recently, within the last 12 months, experienced the death of a loved one. So that's the base, just so you know where this is coming from, all Californians. So based on your experience, what percentage of people do you think would prefer to die at home versus dying in a hospital or a nursing care facility? The little timer is telling you that you should press 1, 2, 3, or 4 on your keypad within 3 seconds now. Did that work for everyone? Yes. Okay. So now, let's see what you think. So we could go to the next slide. All right. 48% of you thought that 70% of people would prefer to die at home. 45% of you, 45% thought 90% of people would, that's hard to say, would prefer to die at home. And a few people thought it was as low as 45%, and someone thought very low. The answer from the California poll is indicated in that little sunburst, and it's 70%. So this audience really believes that people prefer to die at home even more than asking people. So that's kind of interesting. So at this point, we only have 8 questions. Would anyone like to comment on that? Would the folks who thought maybe lower, the 45% people, or even the 20% person. Anyone like to comment? And this is not to target you out, because this is not a right or wrong or, explain yourself. This is really to generate some discussion on this topic, because this is important. Yes?
I think that
we have a microphone, and probably the organizers would like you to say who you are and where you're from.
I think that there was a national Gallup poll, actually, and the results of that poll showed 89%
Okay.
across the nation.
Okay, that may even be a newer poll than this 2011 poll. So you, who said 90%, you're closer to the national average. There was.
I'm Marilyn Shirk
Hi.
from Cedars-Sinai. I said 45% because I think the other question is, would your family want you to die at home?
Uh-huh. And you think that's.
I think that I might want to die at home, but I don't think my family would want me to die
Right.
at
So
home.
that's raising this huge issue of what role do caretakers have in this? And should this poll really be of caretakers in particular? And perhaps there are polls like that, and perhaps we'll discuss them. Okay, so speakers in the room and discussion leaders, you've heard some opinions. Let's go to the second question. Based on your experience, which of the following desires would you expect to be most important for patients nearing the end of their lives? And I'll just let you read them, and as soon as the timer comes up, please cast your vote. No double voting. We're in election season, so we're going to have poll watchers. Oh, and we have the Jeopardy music. Was everyone able to get their vote in? Yeah. Oh, was that, I heard some no's? I'm not sure if we can back up. Well, sorry if you missed it. You got to do early balloting next time. So this is interesting. When I looked at the California poll, so 67% said not financially burdening their families, and about the same number said being comfortable and without pain. But look at living as long as possible. Folks are really saying maybe that's not the thing that I'm trying to optimize here or maximize. And having healthcare providers who will respect my cultural beliefs and values, that was up there. But here we're seeing that it's really being comfortable and not bothering the families, financially burdening them. And again, that interacts certainly with what caregivers would feel. Would anyone like to comment on this? Is this a surprise to anyone? No? Kind of consistent with what you think. And, most people, 86% were right on target here. Okay. There's no comments on this one. Yes, please.
So was this question a Likert scale for then patients, because the 66, 67, that's more than 100%?
Yeah, they were
Okay,
able
that
to
was
do
a Likert.
multiple answers.
Okay.
It wasn't a Likert scale, it was a multiple option, multiple response, yeah. We decided not to get too complicated with that. Okay, let's go to the third question. Based on your experience, who do you think would be most likely to express a preference for living as long as possible among these four racial groups? And here, you can do multiple responses. So we did get a little complicated. Okay. And the timer, please, and the music. But if you vote, we can eliminate the music. Okay, let's see your responses. So, actually, wow, pretty good in terms of us knowing what the Californians feel. I think this is accentuating that we should be sensitive to cultural issues, to who is coming, who are we talking to, and what might their preferences be. And anyone want to comment on why they think Asians might have had a very low percentage of living as long as possible? Does that resonate with people? Anyone have experience there that they might add to help elucidate this? I'm not sure that I quite understand it. No? But yes.
Yeah, I think the confounder here is the literature's pretty clear on African Americans not, wanting aggressive care at the end of life, and that has to do with some cultural and historical issues. But wanting, I'm sorry.
Yeah.
Sorry, did I say not wanting?
I was
Thank
waiting
you.
for that to come.
I probably need some more coffee. But anyway, it's not wanting. And so is that the same as this? It's not clear to me that it is. So, but that may be confounding this.
That might help explain. And did you introduce yourself?
Oh, sorry. I'm George Hanzo.
Okay, thank you. Any other comments? Okay, yes.
I'm Judy Thomas with the
You have
Coalition
a,
for Compassionate Care.
I think there's a mic coming for you.
Judy Thomas with the Coalition for Compassionate Care. We did some ethnographic research with funding from California Healthcare Foundation and Point Forward. And I just say with the Asian population, it's complicated because there's layers of when, I'm really extrapolating here since I'm not Asian, but I think when people who are often of that descent are answering those questions, they're not just thinking of themselves, but they're thinking of their community as well. So they may not quite interpret it as straightforward as we think the question is.
Okay, that's, you're going to a sensitivity that I have in my role at USC, and that is that we need to do focus groups. We need to understand when we ask people questions, how they answer the questions. And let me give you one good example that goes to what you were saying, and that is when we ask Mexicans versus U.S. citizens about their health, and then we go and look at how they're answering those questions using cognitive interview techniques and focus group techniques, we find that Mexicans are going and talking more about how it impacts their family. So health is very much related with family issues, whereas in the U.S., it's purely related to symptom issues. So you get different rates for Mexicans and for folks in the United States, but it's largely due to how they're interpreting the question. So with all of this, we need to keep that in consideration. That's a really good point. Yes?
Good morning. My name's Mark Blight, and I'm from Kaiser Permanente, actually at Sunset Hospital. I wanted to follow up on the African American discussion. I see that I can't see all the way over on the other side of the room, but it doesn't look like there's a lot of black faces in the audience.
I think you're right.
And I think one of the issues that underlies this is a lack of trust in the healthcare system. So when the statement is made that they want everything done or they want all treatments, it's because they're afraid of not getting the treatment that they're for their loved one. And there's also a large, depending on the community, large religious underpinning to the way that some of these decisions are made in families, because they don't want to be making the decision about when someone should die. There may be theological beliefs about that, or just family beliefs that the person should be able to live up until their time is done, and they don't trust the care providers telling them that we need to limit treatment. So it presents a considerable issue that merits a lot more discussion with that community.
Right. So clearly a one-size-all-fits-all approach is not going to work here, and this discussion is emphasizing that. Yes?
Hi, I'm Yolanda from Harbor UCLA, and I have to kind of agree with African Americans. What I find in our hospital is that African Americans say that they have great faith, and their faith is they believe in a miracle. And at some point, either it's going to be a miracle or it's not. But you have to remember that a lot of these people have been in church, and they've heard over 40,000 hours of how God is going to deliver them. And now they're just meeting this healthcare provider, and the healthcare provider is saying, there's no hope. So what do you believe? What you grew up with as a child, or this person that you barely know? So I think that's where it's coming from. and then toward the end of life, as they get closer and closer, then they become a believer. And it's up to, I think, the palliative care team or their providers to help nudge them or help them to realize that the miracle may be actually going to see their Creator and not living this type of life that will be, painful for them.
Mm-hmm. Thank you. Yeah, I think this is highlighting a very large question for all of us, and that is, what are the goals? What are the outcomes? How do we measure what we're trying to achieve with all of the terrific policies and our clinical efforts? Because we have to understand that first to know if we're effective and if we've gotten there. And at least from some discussions I had during the breakfast session, that's still perhaps at some distance. And that interacts with all of these other individual differences that people have, and maybe we'll have a discussion of that at some point. There was another question? Yeah. Or comment.
See the same question, based on the last two comments, see the same question formulated with religious beliefs. For example, if you are a evangelical Christian or Baptist that we're talking about, maybe in the African American community, or Catholic, to sort of, or Buddhist or Muslim, it would be interesting to see how those things and their commitment to their religion, how that affects these decisions.
Yeah, terrific. And I heard you say that's coming.
I said that.
You said that. Okay, sorry, just heard from this ear.
I'm a ventriloquist as well.
You're ventriloquist. Oh, this is a good audience. And could you just say a word about how is that coming?
I'm familiar with the research, and I know that that's something that it would eventually come up in terms of the discussion of religious beliefs and your faith. One comment. My name is Michael
Here,
Demerance.
why don't you grab the mic?
My name is Michael Demerance, and I'm in private practice in Orange County. And I'm also an elected commissioner for the Commission for Case Manager Certification. And the issue really, all of this stuff it really doesn't matter. We really need to talk about what good medical care looks like and provide it to the patients. Because if we provide good medical care, they will go along with the things that are needed. Because good medical care is much better than bad medical care.
Indeed. How about one more comment? I was worried that we wouldn't generate discussion. I don't think I have to worry about that. So that's terrific. How about one more comment on this topic?
Sure. Good morning. I'm Vincent Nguyen from Hoag Hospital. I was very intrigued with 18% Asian, and I hear various discussions. I really think that, when you talk of Asians, there's not only Japanese and Korean, there's Vietnamese and multiple sects, as well as how well these people are enculturated in the community as well, in addition to the religious belief. So I'm sure we'll be discussing more about this today.
Yes. Okay, well, thank you for that really nice discussion. Let's go to question number 4. We may not get through all 8 questions, and by the way, that's just fine. So, do you believe that there has been significant progress over the last 2 years in improving the quality of end-of-life care in California? And let's go to the timer. I feel like I have to say there'll be a prize for someone at the end of it. All right, let's take a look at the results. Okay, about almost 2/3 think yes, 23% no, and a lot of people not so sure. How about someone from the no camp telling us why they're making that statement? And again, not as a challenge, just to inform us about what you're viewing. Anyone willing to volunteer? Yes? Okay, great.
Hi, I'm Rabbi Janet Madden from St. John's, Providence St. John's Medical Center. I think that there has been a great lack of progress, mostly because people are not dying the way that they want to. What they say and what actually happens are two completely different things. And that I do think is the collision between what medicine can do, and the question is that what we should be doing?
And where do you see the discrepancy? Would you say most people would like to do one thing and it doesn't happen?
We saw earlier that, most people say, for example, that they have a preference to die at home. Many people say they have a preference for a limited amount of interventions, but what actually happens is quite different.
Okay, and we have a question coming up along that line. Would anyone from the yes camp like to say what they're seeing that's making them say, yes, it's improved?
Hi, I'm Kate O'Malley with the California Healthcare Foundation. And as I look at the last decade in California and look at all the levers for change that have popped up in the past couple of years, I look at regulatory changes, I look at legislation that requires Medi-Cal plans to provide palliative care to their beneficiaries, I look at educational efforts for workforce development, I look at health plans doing reimbursement strategies to pay for palliative care. None of this was happening 10 years ago. So I think the climate has really changed. I think it takes a change in the culture of healthcare to really get us where we want to be. So I think there's certainly a long way to go. But the levers for change are in motion, and it's not just heroic people at the bedside trying to do the right thing. I think the system is changing. It's slow, but it's happening.
Okay. Yes.
Hey, thanks. As an academic, I'll always speak for the I don't know camp.
I know that one.
Since I'm paid to be part of it. But in all seriousness, I think I really don't know. And part of the reason I'm concerned is because the information we do have about progress in care actually suggests that it has gotten worse over the last few decades, at least at the national level. 2/3 of people experience really significant symptoms, and it's monotonically gotten worse over the last decade. That's in the U.S. population. And care has become progressively more aggressive, where hospice is a tacked-on experience at the very end. We have profound problems in hospice care in terms of for-profit, not-for-profit differences, challenges with inadequate visitation near the end of life in a certain cadre of small hospices, and a lot of disparity in the way that hospices do their job. So I think there are reasons to be concerned. There are reasons to be optimistic, as Kate expressed. And I'd like to be an optimist, but I really don't know. And it gets to a more profound issue, which is really, why is it that we don't know? And why don't we have really good and public statewide knowledge about the experience of patients and families near the end of life? And why isn't it really clear to everyone? I think whether we're doing well or not, we need to know. And so I'm just really concerned about that.
And perhaps the committee that Mr. Schaeffer is heading will have something to. We have all confidence, but so more information is needed, so we know how we're really doing, and then what problems there are to solve. So, all right, thank you. Let's go to question 5. Based on your experience, do you think that patients who choose aggressive interventions towards the end of their lives make this choice with an accurate understanding of the likely quality of life that will result? In other words, do patients understand the implications of making aggressive care choices, aggressive intervention choices? So, long question. Let's go to the timer. And, okay, whoa, we have a clear winner highlighted in green. So everyone is saying that, not everyone, but, well, almost everyone is saying that people aren't understanding what's going to happen when they make these decisions. And, frankly, perhaps you, the audience, maybe you know, but I don't know about if someone was to offer me choice A, B, and C, what the probabilities are that certain things would happen thereafter. Some economists talk about these as shadow information. In the world of subjective well-being, we talk about trying to identify these sorts of things to provide people with information. It is we can provide information. It still is a tricky thing because the information needs to be interpreted in certain ways. But clearly, this audience thinks that we should be getting more information out to folks. Anyone like to comment on this? Yes. Sarah's getting you the microphone.
It really comes down to this, is that we as Americans believe that death is optional. And that is something that is part of the culture, and that we're teaching one. There's no collective experience, oftentimes in families, that can lead from one death to the next to understand what really should be done.
Dana.
Dana Goldman from the Schaeffer Center. I think there's a monolithic view that patients need more information and that everyone can equally process the information. You have people at older ages who are cognitively impaired. You have proxy respondents. You have people who don't have caretakers who are reliable or that you think have the patient's interests at heart. And so the notion that there is one right strategy that involves complete understanding. In some cases, the healthcare system must act as a proxy for what it thinks are the patient's best wishes. And so we're ending up in this bifurcated world where you have some families that are quite sophisticated and patients and others who need help. And I think that's there's different policy strategies in both those cases.
Right. I think Dana's focusing on the decisions that one would make and who makes those decisions. I don't think you disagree, though, that having information about what the probabilities are if you're in this condition and you take this option, where that leads you, that could be used by both hospital folks and by families.
Maybe I'll use my 10 minutes later, but the reason I'm disagreeing is
So much for my accurate summary.
Because this suggests a research agenda that's attuned towards making sure we can elicit everyone's preferences. And my point is the research agenda needs to be tweaked to understand under what circumstances should we be doing that.
Okie doke. I think that, for me, is clearer, yeah.
Hi, Stephanie Elkins, Compassion and Choices. I think one of the words, and some of the word is conversation. So it's not about just providing education, but that idea of patient-centered care and meeting them where they're at on their goals of care and conversation. So it's more of leading, not just providing information, but meeting, once again, what we're doing here is being culturally sensitive of how people take in information, but being able to provide it and ask the right questions and goals so they can respond in a way that works for them. And I think that there's more resources and stuff coming from that perspective of so the patients are able to kind of, and the families able to share what are their really goals of care,
Yep.
at end-of-life care.
So clearly something that seems rather straightforward has a lot of nuances to it, important nuances that need to be considered, need to moderate how we use information, how we think about this. We need to have the discussion so that everyone knows those and researchers factor those things into the research they do. Was there one more comment?
Hi,
Yes.
Wendy Cole-Hayes, clinical bioethicist. I wanted to add to that I also think that it's an obligation on the healthcare provider's part to be a little bit more forward when they think things aren't options, to not offer them up, because I think oftentimes if it's offered, people are going to take them. So maybe a bit more informing and guiding rather than asking.
Okay. All right, maybe a couple more comments.
Thank you for that comment. I'm Sandra Rome. I'm a clinical nurse specialist from Cedars-Sinai. But anyway, I agree with that. It's like a lot of times the aggressive treatments shouldn't even be offered as an option. Because then you're putting the burden on the patient and family for saying if they don't do it, then they're going to feel guilty. So I agree with what you.
How is it we've gone from a 90% agreement to what I'm feeling now is, a lot of different opinions about this nuance part?
So Stuart Finder also from Cedars-Sinai, just to shake it up even more, there's an interesting presumption in the question that quality of life is actually the central focus or should be the central focus,
Exactly.
and that itself has to be a question.
I tried to say something along that line earlier about, I used the term outcomes, maybe quality of life, maybe immediate mood, maybe all of those things are not what we're trying to strive for. But then it comes down to, and I deal with this in some of the research I do, who makes that decision? Is it the clinicians that make it? Is it the policymakers? Is it the person? And that's a societal issue. What stakeholders are here? A lot of stakeholders. Who makes the decision about what counts and what we should optimize? So I think we'll end with this question, but we'll have a few more comments on it. Or you want to? Okay. Well, you're the boss on this. Notice. Yes, please.
Hi, I'm Zara Ismail, palliative care physician from White Memorial Medical Center. Oftentimes I see when physicians are talking about different interventions, they focus a lot more on, well, why don't we try this one intervention? And then the patients feel as if they're going to get better, even though they might suffer a little bit more with a particular intervention. So it's not a clear discussion about the benefits and burdens and quality of life. And then patients kind of get stuck in this journey of, well, we did one intervention, there was a little complication, now let's do 1 and 2 more interventions, and they just get stuck in this path where nobody can get, them out of it. And so now we're talking about a lot of suffering and maybe even end-of-life issues.
Thank you. Yep. So, should we? Yeah, maybe another question. Can we go to question 6, please? What, in your experience, is the single greatest barrier to discussing end-of-life issues with patients? And you can read them. And maybe now we can go to the timer for the voting. That's not an option. All right, let's see the results. Feel ill-prepared to discuss with patients. I presume this may be coming from the clinicians in the, well, actually, I'm not sure if it's coming from the clinicians or from other people who think clinicians aren't prepared. And then not enough time giving other responsibilities. So those are the two that are 70% think that those are the greatest barriers, and then 14% are on wrong setting to initiate conversation with patient family. But these are serious issues. If this was indeed from clinicians, feel ill-prepared to discuss with patients, that's a problem, and that goes to obviously training and policy and having enough time to do it. Number 1. So we have some comments. Here we go. Someone already has a mic, and then this gentleman here.
Hi, my name is Deborah Greenspan. I'm pretty shocked that people perhaps believe that we have a fertile ground to have a conversation when we just got a conversation about funding for education in palliative care. And I really think that inadequate reimbursement for this activity and for the understanding that goes around this activity, the education required, the time it takes, the repeated education. It's not in policy, and it needs to be in policy, and it needs to be funded, fully funded.
Right. And how do you work that into the various training venues? That's very, very difficult. I've worked in a medical school for 37 years, and I know sitting on those committees, it's very difficult to get these kinds of issues into a medical curriculum that's chock full of essential stuff. There was another question, comment?
Hi, my name is
another one here. Then.
Brad Rosen. I'm the medical director of our supportive care medicine program at Cedars-Sinai, which is what we renamed palliative care. I agree with your point around the funding. I think that there is obviously a bias in this room around not selecting number 5. I think the vast majority of practicing physicians, certainly in our area, don't feel like it's their responsibility. Clearly, the people in this room do feel like it's our responsibility, but this is not necessarily representative of what we're facing, I think.
I think that's a great point. Yeah, you wouldn't be here if you felt that, probably. Okay, another comment?
Hi, Murali Naidu from Dignity Health. Amongst my many hats, one that I wear is that of a general surgeon. And, I think it actually goes beyond just feeling prepared. What I see in our hospitals amongst us clinicians is the sense still that we are failing if we don't solve the health problem that is in front of us. And so I think it's not just feeling prepared again or really having patients that are ready to think about this. It's also getting clinicians to move past our mindset that if somebody dies, then we failed. If we didn't cure somebody of cancer, then we failed.
Right, going back to what is the goal of healthcare at end of life? Big question, yeah. So, I'm sorry, one more.
Yeah, I was less than transparent before. My name's George Hanzo. I'm a chaplain. So I would first have a plea, and that's to, when we use the word clinician, I think the presumption is we're talking about docs and nurses. I don't know. I would suggest that we who are chaplains and social workers in the room also consider ourselves a member, and Shirley O'Screen is smiling at me. So we need to be careful about the terminology.
Yeah.
But the other thing is the Tracy Balboni group work at Harvard actually supports this finding among nurses and physicians.
Okay, and thank you. I really did mean to be inclusive there. Yeah. Perhaps we'll do one more question, since we are a little bit behind. Is that all right, Kukla? Yeah. Okay, number 7, please. Has the decision on the part of CMS to have Medicare reimbursement providers for end-of-life care discussions made a big impact? In other words, has this policy decision made a big impact? And we could have the timer. Let's see what kind of agreement we get here. We need a not yet. All right. Let's see what we think. So some folks are saying that it's already had an impact. A lot of folks don't know, and about 40% are saying no, and perhaps that goes to a not yet. Anyone like to comment on this? Are the people who are saying no, is it pretty much a not yes, or is there something intrinsically wrong with the way this is being done that you'd like to comment on?
Yeah, hi, Becky Emerick, palliative care physician, currently with the SCAN Health Plan. But, I trained with Carl Lorenz over there in 2005, 2006 at the West LA VA and been working in palliative care for over 10 years. And I think about when we started, like just begging people to even talk about it and how we would get tarred and feathered and, like chased, out of the room. And things have really changed a lot. And, I think every little step makes a difference. And so the fact that CMS has recognized it as something that's worthwhile, we've come a long way since death panels, 4, 8 years ago, so I think it has made, it's slow, it's frustrating how slow it is, but I think it's doing something.
And it's good to see you've recovered from that tar and feathering. Do the last question. Okay, last question. Which driver of change do you expect to have the most impact on end-of-life care? No one ever said this was going to be easy. And I promise it's the last time you'll hear that song today. Okay, let's take a look at what we think. So, quite a clinical leadership, patients and families are the biggies that we think are going to drive change, but actually all of them, policy leadership and reimbursement rates, seems like there's an argument to be made for all of these. Would anyone like to comment on any specific? One comment, or maybe not. Yes. Why don't you hold for a second? Thanks.
George Mack from Hospital Association, Southern California. I want to tie this back to the previous question about CMS actions and impacts. although CMS has done what they've just indicated, that they're giving some reimbursement effect, the CMS is still paying for inappropriate and wasteful care. And it's an inconsistency that needs to be addressed at the policy level.
Okay. Thank you. Well, we've come to the end of this session. Thank you very much for your participation. I think that although there's a lot of agreement, I think there's lots of room, lots of different opinions in the room, and I encourage you to keep raising questions and stating your opinions throughout the rest of the day. So thanks very much. It's been a pleasure.